Hello and welcome. Thank you so much for taking the time to talk to me today. Elan, can you tell me a little bit about your background and kind of how you got interested in the field you're working in?
Sure thing. So thank you for having me, Karina. I appreciate the opportunity. So I'm a physical therapist by background. I started my career in neurorehabilitation and got interested pretty much right away in pain in the clinic and seeing that some of the patients we were working with had very little damage in their body and had severe pain, so maybe a mild case of scoliosis and severe back pain,
Mm,
and other patients had huge structural pathology and very little pain. And it was very confusing because the framework that we had been taught to work with was very much that, pain was equivalent to structural changes or damage or inflammation in the body. And the treatments were trying to fix those changes with the theory that you fix those changes or those problems as they get better, the person has pain recovery. But in the clinic, that's not what we saw. That's not what I saw.
mm,
And I felt also very frustrated that a lot of times, treatment doesn't work. People don't have the ideal recovery that we're hoping that they'll have, particularly as it relates to pain.
mm,
And so I got very interested and there's got to be more things, something else going on here that we can use, that we can learn about. And so I went on a journey of exploring a lot of different approaches and ideas. Yoga, I became a certified yoga instructor. I thought that
mm.
bringing in some aspects of yoga would be helpful. And some other approaches as well, but where I really got fascinated and went down a rabbit hole that I've never come out of is around pain neuroscience.
Mm.
And when I learned that there's been decades and decades of all this literature, hundreds and thousands of studies about the pain system that I never learned about in school,
Mm.
and that I was quite confident many other people have never been exposed to or seen. And that was really profound that like there's just this huge gap between all this research that's been done and the clinical care that we deliver, that we've been
Mm.
trained to deliver. And so that set me off in a few different in a few different ways. That's basically really the inspiration of how I got really interested in pain. And also I grew up in a family where I had several family members who were living with very, very severe neuropathic pain,
Mm.
severe back pain. And so it wasn't something I had, kind of more mild chronic pain that I've experienced, but I grew up in a family where there was other people who were dealing with really severe, debilitating chronic pain. And so that was also from that angle something that was very interesting to me
Mm.
as well.
Yeah, neuropathic pain is really one of the worst, I think, because it's just like not responding to any sort of pain treatment much. So I do have some like small fiber neuropathy pain, but I'm like a mild case, but it's still, I can't even describe this like burning sensations, like, your feet are on fire. It's horrible.
Yeah, and I think in particular, like for a lot of musculoskeletal pains, a doctor might prescribe a medication or they might do a surgery to fix some structural pathology, but like when it comes to neuropathic pain it's very hard. What structure are you trying to fix? The nerves are not firing,
Mm,
or they're firing too much. And then when you come to physical therapy, so much of what we have in physical therapy to offer is movement based, and there is some evidence that certain types of exercise can be helpful, but it's not really touching the core of the problem. And so it really is challenging. How can we treat neuropathic pain?
well, so you said you get really interested in neuroscience, and I know you work like in the field of neuroplasticity, but I didn't quite know what that was before you mentioned that. Can you explain what neuroplasticity is?
Yeah, so I use the word neuroplasticity because, like, in the field, that's kind of the most common. But some people are saying we should actually really use the word like bioplasticity, which
Mm-hmm.
is that the nature of biological things is to change, that they're adaptable. Things are changing. With the cells in our body are living and they adapt and they change in all sorts of different ways. And some of those changes can make pain worse,
Mm,
and some of those changes actually can be harnessed to improve pain. And so I think like at the core of it, is first this idea that we have a pain system. That was never something that I really appreciated, that we actually have a system in our body for pain. And it's nerves, it's immune cells, it's all sorts of structures and networks in the brain. And just about nothing in the pain system is just for pain. Everything is also kind of involved in other stuff, but there really is a group of structures um, and processes in the body for pain. And that system is changeable. So that system is not static, and it's very much, I just think of like a caterpillar and a butterfly, how this, same organism can just transform. It's the same thing in our biology as well. Our pain system can transform. It can change, and it can change to produce more pain or produce pain more easily. And so if normally like we have this amazing pain system which protects us because if we're accidentally hurting ourselves, if your foot is on fire, literally on fire, you want to feel that quickly, and you want to like prioritize that and deal with it right away. Nothing else should be as important, because you can't just be like, well, I just want to like finish this phone call, or just, it's like, no, this has to dominate your attention. This needs to grab everything and really motivate you to take care of it. So it's a beautiful system that we have. And there's actually a small percentage of children who are born without the ability to feel pain, and they get these horrific injuries early on because they don't sense that something's that can bite on their tongue, like bite off their tongue, so we have this amazing pain system, but these nerves and these synapses and these connections between these nerves, they can change, and the whole system can get like ramped up. The volume can get ramped up. And so for some people, for some interesting reasons, which we can talk about in a few moments, but for some people, the system gets ramped up. And so if you touch them, normally it shouldn't hurt when you get touched. It should only hurt when you're getting punched. But if the system is ramped up, it can hurt when you're even just touched, or it can hurt when you're just moving your arm a little bit. And so instead of getting pain when your body is in danger, you're getting pain even when your body's not in danger. So you're getting this excessive pain. And those changes take place in the little nerves, in our tissues. It takes place in the spinal cord, and it takes place in the brain. There's many changes, different types of changes. And all together, when those changes are causing disability, when they're impairing quality of life, they're referred to as maladaptive neuroplasticity. Neuroplasticity changes in the nervous system that are not helpful. They're not helpful in the moment. But neuroplasticity goes beyond the pain system. Neuroplasticity is also the way we learn. If you're doing some, I don't know, physical skilled task, it's not the same the first time you do it as the 1,000th time you do it, or playing piano or playing music. So it's also neuroplasticity. As you repeat, the synapses change, the connections between neurons change, and it becomes easier to fire those pathways. Well, that's what happens in the nervous system with pain. If those pathways are getting activated and activated and activated, it becomes easier to activate those pathways. They become more efficient. And so now even smaller stimuli create pain. And so that's kind of like a brief overview of neuroplasticity in the pain system. Now, some of it is really good. So like if you break your leg, God forbid, you break your leg, not just when you break your leg, but for a few weeks after, because you need to remind yourself, like, it's not a good time to run a marathon. It's not a good time to take a big hike. So you have this extra pain that comes with inflammation, extra sensitivity, and that reminds you something is healing. Be careful, protect it. But if that extra sensitivity stays for too long, or it spreads to other body parts, or it just gets like totally out of whack, so now even like the sheets of your bed are now causing pain, that's too much. And so that's this maladaptive neuroplasticity, and where it's really a really exciting aspect. So the first thing is like there's been all this research to show this, to measure this, to find this. Many people don't know about it. And so people assume that if they're in pain, every aspect of their pain is simply a reflection of how much damage there is in their body, or how much inflammation there is in their body. But we now know it's much more complicated. Yes, there might be damage and inflammation, but then there's also this other element of what's the sensitivity level. And then as that relates to treatment, so it's not enough to look at whatever that original injury was, or that original cause of inflammation. At a certain point, you have to say, okay, there's a much more complex picture that's going on here, and how can we address, let's say the injury or the inflammation or the underlying disease, but also what can we do to turn the volume down in the sensory nervous system? And so the treatment plan needs to be more holistic. It needs to be looking at these different kind of aspects. And so I'm really excited by these possibilities of like, okay, what is the opportunity for this positive neuroplasticity? How can we get the volume to turn down? What kind of repetitive activities can we do that will actually do the opposite and turn the volume down? And then, what can we do in the clinic? What kind of technology can we create? What kind of information can we share with people to empower them to bring that into their treatment plan?
So you're basically saying that there, like in EDS, you have this like acute pain, right? When you dislocate something, for example. I mean, that hurts. So that's kind of acute pain, but then you also have the chronic pain where you might get like hypersensitive to a stimulus that's not that bad anymore, right?
Exactly. And so it gets really confusing in conditions like EDS,
Yeah.
because you have this like structural thing going on, right? There's very clear things in the tissues that are not the way they should be, right? There's a problem. But on top of that, because you've been dealing with that, a person with EDS has been dealing with that, year after year, and they're having all this extra input to the nervous system. On top of that, you get layered this hypersensitivity, and so you wind up with multiple things going on at the same time. So in some pain conditions, it's very much just the structural stuff is the key thing. In some pain conditions, it's really just the neuroplasticity, or it's just these changes in the central nervous system. Like, so there's pain syndromes, for example, where a person has a stroke, and they develop a pain that's actually a damage in the central nervous system that's creating kind of changes and excessive pain. There's no, let's say, structural thing in their, hand that's the problem. It's all, central nervous system changes. But with something like EDS, you have this kind of layering of multiple things. And I think that where, it's really important is to always think about like, what's my holistic treatment plan, and how are different aspects of my plan targeting these different aspects of the pain. It's not just one thing. And it can be very, very difficult to tease out, which pain is this and which pain is that. And maybe it's even impossible. Maybe at a certain point, it's all kind of together. And it's very hard to say, well, this is this and this is that. It's just kind of, this is the whole picture. But I think this is very common in EDS, in rheumatoid arthritis also, where you're getting these repeated bouts of inflammation, but over time, that's creating hypersensitivity. And also in things like in conditions like sickle cell disease, also where you have acute crisis again and again, but then you wind up with also this kind of underlying hypersensitivity, as well. And so I think that this is where it gets tricky also from a communication perspective, because so many people for so long have been told that their pain is not real, so they go to the doctor and the doctor can't find anything. And so the doctor will say, well, we don't know, or it's in your head, or psychological. And so there's this whole like history of that stuff. And particularly for certain demographics, for certain types of people that have been historically, pushed out of the system and told, well, you're just a complainer, you're a hypochondriac, especially for conditions where there's a lot of different symptoms and it doesn't fit a clear, category. And so because of that history, when a healthcare professional starts to talk about the brain or the nervous system, it can seem like, oh no, here we go again. This person is saying, it's not real, it's in my head. And so now we have this opposite problem where people are like, I've got a structural problem. It's real. I'm telling you it's real. I saw it on a scan. There's a genetic test or whatever, but it's always all these factors coming together. And the treatment plan is almost always going to have to kind of hit these different things. And so, that I started a nonprofit organization called the Retrain Pain Foundation to share pain science in an accessible way for people, because I think that there is this like divide, especially with chronic pain conditions, where it's so hard to talk about these things without getting people feeling like their pain is being dismissed.
Yeah.
And so, if we have a language of science, all these things that we're talking about here, they have names, things like central sensitization and other terms. These are real physiological processes. And if we can have a language and also acknowledging that these changes in the nervous system and the brain, they're real, they're
Mm,
structural. You can measure them. These are not, is no one's imagining anything. These are real physical changes in synapses.
mm.
Um, and they're biological changes, just like the biological changes in the skin or in the blood vessels or in muscles and joints. And so we need to be talking about and trying to address all of them.
I feel like you kind of read my mind because that's why I just kind of wanted to mention that we have acute pain and chronic pain and all that because the whole thing it's all in your head, and then also because you mentioned you're a trained yoga instructor, because people with EDS are getting told that you should just do a little more yoga for your pain. So you're not saying that if we just trained the whole neuroplasticity thing, then our pain goes away. You're just saying that this could help to maybe lower like the pain threshold a little bit, right?
Absolutely. And I'm also saying that there's a comprehensive approach that people, unfortunately, you go to one healthcare professional and they give you like just that one thing. That's the thing that they do, and that's
Yeah.
it. And really, people, and it's very difficult because our healthcare system is not set up for this. And especially when you're dealing with chronic disease. I have people in my family who have chronic disease that have many aspects to it, and every doctor just wants to take on their one piece of the puzzle, and
Yeah.
they're not all talking to each other, and they're not all trying to come up with a comprehensive plan. And so it all falls on the patient themselves to try to figure out, okay, how do I create a comprehensive plan, and how do I get the right care from each person and put it all together? And especially if you don't have the background, you don't have the education, you don't have the knowledge, it's almost impossible, unfortunately, to do that. But ideally, people should be getting a multidisciplinary approach, and each person, through discussion with their healthcare professional or friends, or just thinking, and has to figure out what are the dominant features of my condition. So for example, we know that when a person doesn't sleep well, that's one of the things that can actually really ramp up sensitivity in the nervous
Oh yeah.
system. So if a person happens to have insomnia or lack of sleep is part of their lived experience, so then addressing sleep could be a really relevant thing for that person as part of their comprehensive pain plan. But for someone else, it could be completely irrelevant. And so the pieces are going to all look different depending on, a person's own lived experience and all the particular factors. And that's where, one of the things that I see getting more popular, and I hope it will continue, is like health coaches around pain, because I think that someone like a health coach can spend the time and just have a conversation and start to think about and talk about really what are some of these different factors that are playing a role, and how can we, kind of create a custom plan. And even then
Mm,
going out to different healthcare professionals. Okay, so I have a sleep issue, so maybe I need to go to a sleep specialist who can then prescribe a specific medication or a specific behavioral strategy.
mm-hmm.
But figuring out the particular pieces. And I think that, and for EDS, or where I think EDS is a really interesting example, actually, that's different from a lot of other conditions where um, I think a person, and I don't have EDS, so I'm just projecting,
Mm-hmm.
but I think that a person could, in a sense, give up on the possibilities of what could improve because you have, in terms of pain, because you have the structural problem in the body. My joints are the way they are, so that's it. There's nothing I can do, or all I can do is things that are going to, let's say, protect the joints. When
Mm.
really there may be a whole set of strategies that might not be a cure, but could be really helpful for improving pain beyond the joints.
What do you think should be involved in that strategy? Like, be just you said you to address the body and the brain, basically. Like, how would this, like, a regular treatment plan look like?
So, okay, so before I answer that, I'll also just want to give one other point that I want to share, is that sometimes when you come up with a comprehensive plan, it's also overwhelming because
Mm-hmm.
you say, okay, like here are all these things I can do. Like I don't have time for all that. Like I can't do all those things. So
True.
so it's one thing is to acknowledge the different pieces and maybe make like a kind of long-term plan or vision, but that doesn't mean taking on everything at once, right? So if a
Mm.
person says, okay, here are 4 different strategies that I want to pursue, I'm going to start with one for 6 months. I'm going to do this one for 6 months, and then I'm going to move on to the next one and incorporate that. But you don't have to try to do everything, all at once.
Mm.
So from a pain perspective, well, there's kind of the EDS thing, and then there's the just kind of pain in general. So for EDS, I'm really not an expert in EDS, but there are rehab techniques. There are different types of exercises. There's all sorts of, and I know it's controversial and there's different responses, but there's things like splints and exercises and different things that have to do with, let's say quote the body, even though the brain's in the body too, but they call it, neck down. And then there's the things that have to do with like the pain systems. That's what I'll talk about more because I think it's more interesting.
Mhm.
People maybe know less about it. So we know that sleep, as I mentioned, plays a huge role in how pain is processed in the body. We know that nutrition. So we know that certain types of nutritional factors. So for example, our brain has this pharmacy inside of it, essentially, where the brain can release these chemicals that come down into the spinal cord and that turn the volume down or turn the volume up. Those are chemicals like natural opioids called endorphins, endocannabinoids, which is basically very similar to what we get in cannabis, serotonin, dopamine, all these different chemicals that can modulate pain. But the brain's got to build them from something. And so there's all sorts of things in our diet that play a role in how easily our body can synthesize those chemicals. And so, for
Mhm.
example, and I'm not giving specific advice. I'm just saying very generally, there's some really interesting research about omega-3s and
Mhm.
how omega-3 fatty acids, how they break down in the body. They're part of a biological process of how our body synthesizes some of these natural painkillers. Similarly, on the other side, our body has chemicals that can actually amplify pain. So, for example, cholecystokinin, which is used in the body for a whole bunch of different things.
Mhm.
One of the things it's used is actually it amplifies pain. When a person is anxious about pain
Mhm.
or worried about pain, cholecystokinin is released and it actually blocks our natural opioid receptors, right? So
Oh,
this is like a wild thing
interesting.
that
Yeah.
really blew me away. So when I learned that, um, or for example, there's a pro-inflammatory chemical. So just like there's kind of natural anti-inflammatory chemicals in the body that are part of resolving inflammation, there's also chemicals that are part of kind of increasing or promoting inflammation, which is a very common thing in many pain conditions. So
Mm.
diet can be a big piece of this. Sleep can be a big piece of this. Movement. Now, movement's a really interesting one because we always think of movement as like exercise,
Mhm.
right? Physical exercise. And we know also that many people with pain, as soon as you do physical exercise, your pain actually increases, right? So you wind up with this weird paradox of like, well, is the exercise supposed to help me or is the exercise, going to make it worse?
Yeah.
Um, and also layered on top of that, fear and anxiety about protecting the body, right? So if you have a body that you feel or you perceive as vulnerable, and is easy to damage, right? You're going to be even more protected. But when it comes to exercise, many people and many physical therapists think of exercise in terms of like sports performance. So they would train someone who's living with chronic pain in the same strategic thinking as they would a Olympic athlete. And the
Mm.
way that we think about, okay, how are we going to strengthen tissues? How are we going to make it easier to, you know, move faster or, just more power. But we know that we now know that many of the effects of exercise or movement, let's just say movement instead of exercise, many of the effects of movement on pain have nothing to do with structural changes in the body. We know that, for example, being sedentary versus someone who is moving more often changes genetic expression in parts of the brainstem that regulate pain and regulate these different nerves that either amplify or inhibit pain. So
Mhm.
there's something about just being physically active that has a desensitizing effect potentially on the nervous system that has nothing to do with how strong or flexible or anything in the structures of the joints. And so what that also means, and again, EDS is its own specific example, but if someone has, let's say, for example, chronic pain in their foot, they can't walk. It's really too difficult. they could potentially get many of the benefits of exercise by moving their arms
Mm.
as they could by moving. They could actually get pain benefit in their feet from regular movement that has to do with their arms, because there's something about just movement in general that has a really profound effect on the body. Now, the other thing about exercise is it has profound psychological effects. So we know
Mm-hmm.
that if exercise, can potentially reduce anxiety, or let's say, for example, you're really fearful about your body, you're fearful about getting damaged, and somewhat rightfully so, if you've been living with subluxations and dislocations. If you work with a physical therapist and you are able to do exercise and succeed and don't get injured, it has a profound psychological effect of
Mm.
feeling more empowered and feeling more like your body is safe, your body is resilient, and then that ultimately changes the way that you go about your day to day, the confidence you have in your body, and that can also have a movement's a big one, sleep, definitely, food.
Mm.
Um, then there's all of the kind of like mental outlook stuff. And also this is another place where it's like, oh, okay, more psychological stuff, think good and it will be good. But it's much more than that. We know from hundreds of studies that the way we understand our pain, the way we feel about the vulnerability in our body changes how pain is processed. And it makes sense because pain is all about protection. The more you perceive danger in your body, the more your brain wants to protect. And so if they've done all sorts of, I'll give you one example of an experiment. If you give someone a stimulus, let's say a very hot or very cold stimulus, and
Mm.
you flash a light before that, either, a green light or a red light, maybe red representing danger, green
Mm-hmm.
representing safety, just that light will change how the stimuli feels. The more clues or awareness that you have that something in the body is threatened, the more pain a stimuli will produce. And so learning about pain even can be something that's helpful if it helps you actually have less fear or worry about danger in your body. And again, that's not the whole story. It's not just that's the whole treatment plan. It's just sit and don't be worried about pain. No, but that can be one important piece. And
Mm.
that piece sometimes then is actually a critical piece, because once you have that, you're then ready to engage in movement or ready to engage in some other behavioral strategy that can be, helpful.
Well, I was honestly just thinking about my recent tattoo experience and how, like, kind of being distracted while you get a tattoo, by music, by talking to people. Like, I did barely feel the pain, but once I was on my own, and there was nothing else besides that needle hammering under my skin, basically, it was hurting a lot more. So is this kind of can we approach pain by like just giving my brain something else to think about? Is that how it works?
Such a good question. So I want to share a few things about that, because this is a topic that I'm really fascinated by. One of the things that I think is so interesting about this whole like idea of distraction, I always thought that, like, you have pain and then, like, okay, you're just like not focusing on the pain as much. And that's kind of the whole story. But it's so much more interesting than that, because it turns out that when you're distracted by something else that your brain has deemed more important. So for example, there's stories of people being shot in war, but they need to focus on survival. Or
Mm.
example I like is, if you step on a thumbtack when you're running away from a lion, you're probably not going to feel the thumbtack a whole lot. So what's going on? So it's really interesting. So the brain actually has these pathways that come down to the spinal cord that can basically turn the volume down. What they found is that if you take an fMRI, so if you actually image the
Mm.
spinal cord during cognitive distraction. So if you give someone some pain, like a tattoo would be a perfect example, you give them this painful stimuli, and then you distract them with something else that they find engaging, you can see a pain reduction, not just in what they feel. They say, okay, I feel less pain. You can actually see a reduction of nerve activity in the spinal cord.
Hmm. So that's basically, isn't that how meditation works as well? Like by basically focusing your attention on like your breathing or something else? Because I've noticed that I respond quite well to meditation in terms of my pain. And I also like I learned to use that when I'm in pain otherwise. Like with a tattoo, for example, I was able to kind of switch my attention even though there was no outside stimulus.
Absolutely. So with meditation, there's probably multiple mechanisms going on, and there's also different meditative techniques. And it could be that some techniques are working in a different way, but definitely, the focus on the breath is probably an attentional analgesia, where, a strong focus on one thing is going to then basically the brain's going to send signals to turn the volume down on other stuff. Um, but it gets tricky because for a few reasons. One is that it's not always so easy to distract yourself, right? So, and the most difficult. So when you were getting a tattoo, I'm assuming you went involuntarily, right? So you
Yes.
wanted the tattoo, and you also believe that the tattoo, while it's painful, it's probably safe. Your body is not actually under threat. Like it's painful, but it's going to get better. And
Yeah.
actually, you are going to even enhance yourself in some way through this experience, right? You're going to come out
Yeah.
better on the other side.
Yeah, I understand there is some sort of like joy involved because I like the outcome and I'm happy about it, right? So it's like probably not as painful.
But if like some strange dude was stabbing you with a needle,
Different.
would you be able to say, well, I think I'm going to meditate now, or I think I'm
No.
going to do something else? No, not a chance.
No, of course not.
So that context is what actually makes the distraction possible. So if you're dealing with something that you feel threatened either because, what does this mean, or my body's in danger, or how am I going to live like this, all those different types of threats, how am I going to pay for my medical bills, all the many different types of threats, it's going to make it almost impossible to ever have your brain switch gears because you're dealing with such a big threat. Distraction works the best when you first de-threaten the source of the pain,
Okay.
and then help your brain be able to shift attention. And I will mention here, so I'm working on another company called TrainPain, and we're developing technology specifically around this area, which is, can we actually train the brain, train the nervous system to get more flexible, to be more flexible in what it pays attention to, with the goal of actually making it easier for people to be able to shift attention. And so, inspired by my work doing meditation in the pain clinic and teaching people meditation, and it's so difficult for many people, meditation. It feels abstract, it's out there, like, why would I do that? Am I doing it right? All that kind of stuff. So we created a video game where we train with this kind of like attentional awareness, but through a video game. So where people can, we have these little stimulators, you've seen it. So
Yes.
so we have these little stimulators, and whereas like in a body scan meditation, you would just kind of okay, now I'm going to pay attention to my foot, now I'm going to pay attention to my arm. What we're doing is something very similar, but in a video game experience where we actually can measure how well the brain is doing that. So we'll give a stimuli with a little tap, like very similar to what you would feel from a smart watch, or from your phone when it vibrates when you get a phone call. And we look at how well the brain can process that stimuli while it's at the same time trying to ignore a stimuli somewhere else. So we're looking at, for example, how well can you shift your attention towards your right shoulder, while you're ignoring your left foot. We can actually measure how well the brain can do that. And then we go in the other direction, and we go back and forth thousands of times through these interactive games. And we're trying to build and promote and strengthen that ability of the brain to be able to switch channels, ultimately with the goal that in day-to-day life, it will be easier for the person to switch channels, so that if you want to be talking to someone, but your mind is being pulled into that pain in your foot, for example, that those kind of muscles or processes will be more efficient. You'll be easier for you to shift attention towards the person you're trying to talk to, rather than just being kind of reflexively pulled into the place of pain. And the other thing we're doing in this experience, which I think is really interesting, is we're trying to de-threaten sensations in the body. So many people living with chronic pain have a repeated experience for years and years and years, where every sensation from a certain body part is painful, it's threatening, it's, bad. And we want to and the brain learns that. And so what happens after going through that for 2 decades, the brain already is expecting any information from my hand is going to be threatening, bothersome. And so the brain is like in high alert. And all that information coming up is already like processed with, high alert, amplification, high priority. And so we want to give the brain an experience of success and reward. And so a person pays attention to the body part, they feel the stimuli, they play the game, they win the game, they have this experience of rewards, all these dopamine circuits that get active when you're playing these games. And we want to train the brain again and again and again that sensations from this body part are safe.
Mm-hmm.
You can actually activate the reward networks. You don't need to be on high alert. And in doing that, to create this kind of neuroplasticity that the brain should get better at being able to turn the volume down and be more flexible in how it attends and processes sensory information.
You just talked a little about TrainPain, which you were kind enough to send me to try out myself. Can you tell our audience a little about what happens in my mind when I do those sensory exercises?
Sure thing. So we're building TrainPain based on some really interesting studies that have been done on these kinds of sensory perception tasks. And they've been done in the laboratory with healthy individuals, and they've been done in the laboratory in several different groups of individuals with different types of pain, chronic pain. And so basically there's different aspects to it. So one of the things is that when in some pain conditions, like this has been studied the most in phantom limb pain, for example, there's a loss of precision in the brain. And so when a person gets a sensory signal, instead of that signal coming through clear and precise, it comes through a little bit blurry. As the neurons are turning on a little bit too much and more than they should, the image in the brain that represents that sensory information is not clear and precise. And that is believed to play a role in the amplifying of sensory information. And so in at least one study, they showed that doing these kinds of sensory perception tasks repeatedly, thousands of times, improved the clarity of the representation of the sensation in the brain. And so that as the information is coming up, it's being represented in a sparse way. So you don't have all of this excessive neural activity. Just what needs to turn on is turning on, and all the stuff around it is staying quiet, and you get a clearer picture. And with that clearer picture also comes reduced hypersensitivity. So that's
Mm-hmm.
one area of research that's been done around sensory exercises. There's another one as well, which is what happens when you give someone a stimuli in one body part that they need to pay attention to, while at the same time giving them a distraction in a different body part that they need to ignore. What happens in the brain?
Mm-hmm.
So we know that if I tell you, okay, you're about to feel something on your shoulder that you need to attend, tell me how many pulses you feel, tell me what kind of pattern it is. And at the same time, you're going to feel distraction in your foot. And this is going to happen in 1 second. Your brain, in preparing for what's about to happen, your brain activates inhibitory networks in the brain. So basically these neurons that turn the volume down, basically your brain tries to shut down all of the processing in your brain related to your foot, related to the area you're trying to ignore. And the brain does this selectively. The brain doesn't shut everything off. It shuts off just the parts of your brain that are going to process information from your foot in a selective way. And at the same time, your brain reduces the inhibition, or another way of saying kind of like prepares to activate the parts of the brain that correspond to the area you're about to pay attention to. And not only, and so if you measure the brain with an EEG, which looks at brain waves, what you'll see is an increase in alpha waves. Alpha waves is one of the ways that the neurons fire when they're trying to be quiet, when the neurons are like, we don't want to turn on. So they'll go into this kind of quiet alpha state. So the part of your brain that corresponds to the body part you're trying to ignore will have a spike in alpha activity.
Mm-hmm.
And the part of your brain that corresponds to the area you're about to pay attention to will have, let's say, a deactivation of alpha. It's a very kind of crude way of measuring, but that's one of the things. And then when you switch, the opposite will happen. So now if we say, okay, now I want you to pay attention to your foot and ignore your shoulder, so your brain now has to do the opposite. It needs to activate the alpha waves in the area that was deactivated and deactivate the alpha waves. And what we're doing in our training is trying to do that repetitively back and forth to train how flexible and efficient the brain can do that kind of switching of what's turning on and what's turning off. So that's the really interesting thing about kind of like neuroscience is what you're going to see or what you're going to measure is depending on the tools you're going to use. So if you look at the brain with an MRI, you're going to see something completely different than if you're looking with EEG. If you look at the brain, you'll see something differently than if you look at the spinal cord. So there's a whole lot of stuff happening when we do
Mm-hmm.
these kinds of tasks, but it just depends on where you're looking in the central nervous system. That's you'd be like, oh, well, that's what's happening. But really, there's a lot of other stuff happening. So one of the other things that's happening, which has not been studied with this specific task, but was studied with a different type of cognitive task, is that you get that inhibition in the spinal cord. So in the area, you're trying to ignore, you'll see a reduction of the nerve pulses even in the spinal cord level when the brain is trying to focus on this other thing. So those are some of the things that are going on. And what we want to do is, I don't believe that, pain is just simply overactivation of neural activity. It's much more complicated. What
Mm-hmm.
really, really want to train is the flexibility and the efficiency of the brain to be able to regulate, to turn things up when they need to be turned up, to turn things down when they need to be turned down, and to train that attentional flexibility or cognitive flexibility of how the brain is being able to switch to different types of modes as it needs to deal with the day-to-day kind of tasks of living. Another thing that is happening relates to what I mentioned before, which is we're trying to train the brain, like in meditation, to pay attention in a different way, right? So you can pay attention with fear and anxiety, or you can pay attention with playfulness and reward. And
Mm-hmm.
so if you were to look at the brain in a very kind of crude way, so we would say that when you're paying attention with anxiety or fear or like protection for threat, that you would have activation of things like the amygdala or regions or what they call the salience network in the brain, which is a whole bunch of regions that are looking out for threats. Those are going to be overactivated and they have a tendency to amplify sensory information, like make it feel more stronger, boost those signals. We want to try to deactivate that and instead activate a different set of neurons in the nucleus accumbens and basal ganglia that are dealing with reward processing, which have a tendency to turn the volume down. And this is actually really fascinating. So one of an experiment that's been done is if you give someone like a stimuli, okay, they feel pain, then you have them win a Wheel of Fortune game at the same time, and they have less pain. And the scientists can see that it's specifically a dopamine effect. So it's specifically a dopamine release when you're winning the game. That is what's causing the reduction in pain from the stimuli. And then where this gets really interesting is if you test this with people who have Parkinson's disease, where they have a problem with dopamine production in the brain. And
Mm-hmm.
if you test them before and after their medication, so you can see that people with Parkinson's, when they win a game, they don't have that reduction in pain that a healthy person would have because their
Mm-hmm.
dopamine circuits aren't working as well. But if you test them right after their medication, they do have that effect. And so there's so many different networks in the brain that you can target in different ways. And in our TrainPain program, we're trying to see, okay, how can we target these different pain networks from a few different angles and take all this information and see, okay, how can we bring this together? And we have a multidisciplinary team. So we have like pain scientists who've done a lot of research about the brain and psychology and cognitive processing. And then we have folks like who have a lot of experience in the gaming industry, like the creative director of Candy Crush and the former chief of game design at Google, and bringing these different minds together and saying, okay, how can we take this like pain science knowledge, and then how can we use games and sensory tasks to take advantage of modulating how the pain system works.
I mean, this is so fascinating and also so exciting because it seems like a very, like, not painful way to reduce pain, which is like, because usually all kind of pain medication comes with lots of side effects, right? So I think everybody with EDS would love something else that, has the same effect without all the like negative things that come along with it.
So we're working on it. I also one of the things that I've seen is that a lot of the so-called mind-body techniques that are out
Mm-hmm.
there, they have a lot of stigma around them. So there are a lot of
Mm-hmm.
people who won't engage in those things because either they're afraid that if they do it, it means that they're acknowledging the pain is psychological and not real, and they know their pain is real, or just because some of these techniques are really abstract and they're just you don't know if you're doing it right. It's hard to like, and also the difficulty is always the same. There's no like
Mm-hmm.
easy meditation. Meditation's hard, it's not easy. And so by trying to come up with mind body techniques that make it more accessible, that make it gamified, that make it more objective, you can see how you're doing. We hope that we can take some of these concepts and make it more accessible to people who haven't been able to engage in other techniques like this in the past.
That sounds awesome. I mean, you need to keep me posted. And also, thank you for your time.
I appreciate the opportunity to share with the community, so thank you.